Good evening to all. It gives me warm pleasure in introducing the next speaker for the day, Dr. Parivalavan Rajavelu. He is a consultant surgeon and a clinical aid quality assurance, Sundaram Medical Foundation, Chennai, possessing 26 years in the field of surgery. He is a man of humbleness who always strives to render quality care to patients. He also being the founder of Skills for Med, Patient Care Skill Training Center. His presentation and publications are many. He has been the faculty for many of the training programs nationally. He is the recipient of many awards and recognitions. Let's welcome Dr. Pari sir to talk on transitioning from TPR charting to MEWS charting. Over to you, sir.
Thank you, Dr. Pushpalatha. Pushpalatha, for that wonderful introduction. I want to start my presentation with a small case study. The 84-year-old lady was admitted with complaints of breathlessness, and a second hourly vitals was ordered. At 2 a.m., the nurse found that the patient's oxygen saturation was 90%, and the other vitals were normal. So this was recorded in the TPR chart. At 4:30 a.m., the patient became breathless, and the nurse called the duty doctor. The duty doctor assessed the patient. Now, there is a small asterisk there. You all know about it. Conditions apply. Okay, this was this doctor's first clinical rotation after graduation, and he saw the patient at 2:45 a.m. And he orders nasal oxygen and goes to see another patient who complains of constipation. This is at 3 a.m. Now, the nurse notices the patient saturation is falling and the respiratory rate is rising. So she's very concerned and calls the same doctor again, and this is at 3:15 a.m. The doctor orders for a Venturi mask at 3:30, and by the time the nurse is getting the Venturi set ready, the patient arrests. And the nurse dials the code blue. So here is a story which started really at 2 a.m. and finished at 3 almost with 2 hours, and you could see that there is so much of delay. Now, what are the dangers of delay for the patient? There are statistics to show that 1/3 of potentially preventable deaths are due to poor clinical response, especially sepsis, cardiac emergencies like STEMI and stroke are time critical events, and even minutes of delay can mean the difference between life and death, or even huge morbidities. And there is also statistics to show that reducing code blue calls improves outcomes and optimizes resources. So here is the temperature, pulse, and respiration chart, which we are all familiar with, and this is what we used in our hospital as well. So it gives a visual representation of the temperature, and you can see the values of the pulse, BP, respiratory rate of the patient, in addition to other parameters. For example, now our chart also takes into account intake and output, diet, and whether the patient had bath. Now, the drawback of this traditional TPR chart is that it isn't, as it says, it's an observation chart. And nurses are trained to observe, but not to act on this chart. No, they're just passively, they just keep on documenting it. And the chart also is not standardized. It varies from place to place. And the detection of patient deterioration is not very easy when you look at this chart. And very, very importantly, there is no mechanism of calling the competent doctor. Now, competent doctor is a very politically loaded term. Usually we say senior doctor, but I tend to differ on that, and I put this word competent doctor for reasons. But in my hospital, be sure I only talk, it is a senior doctor. Okay, so here is the MEWS chart now we introduced. As you can see, we introduced in January 2020, and this chart we use this chart to document respiratory rate, oxygen saturation, use of supplemental oxygen, blood pressure, pulse rate, level of consciousness, and the temperature. So it charts all the vital parameters. Now, this MEWS chart can be used for continuously assessing the patient and also for triage in the emergency. It is used instead of the TPR chart. It provides a standardized scale, because everyone, if you use the MEWS chart, and if nationally we adopt it like they have done in the UK, every hospital in the UK only has this chart, and that is the beauty of it. It is so standardized. And in fact, in the UK, it is called the National Early Warning Score, NEWS, and not MEWS. But now this has spread to other countries as well. Now, there are some points to remember. The MEWS chart, which we are going to discuss in this talk, applies only to the adult patient. If you want to monitor pregnant patients or pediatrics, you have to use a separate chart. For pregnant patient, we have something which sounds like a cat, MEWS, and there is also a pediatric early warning score, which is called PEWS. Now, before getting into how we use the MEWS chart, we need to understand what are the strengths and limitations of this chart. The strengths are it accurately predicts the worsening of patient's condition, facilitates easy communication, just like the GCS chart, Glasgow Coma scale. Everybody knows if I say the Glasgow Coma scale is 8 by 15 or 10 by 15. Similarly, the MEWS score gives a very easy way for communication. It can be automated in electronic medical records and can be applied across specialties. When I say specialties, is medical and surgical specialties. There are limitations. It requires a nurse's active involvement because, as you will see, it requires a lot of tasks from the nurse's front. And another thing is, because it is so objective and score-based, sometimes the nurse's clinical judgment can be overlooked. So this is something you have to be careful about. Now, the benefits of MEWS chart is that it is very useful for clinical response. So when we say clinical response, there are three elements which are very, very critical. One is early detection of the patient's deterioration, timeliness of the response, and calling the competent doctor. If these three things are done, definitely a lot more lives can be saved. Now, MEWS charting involves a 4-step process. It is pretty simple, actually. So the first step is documenting the vital parameters. You can see on the arrow on the showing that the vital parameters are on the left side. The second is you have to assign the score. So there are the chart itself is color coded. The white is given 0, yellow 1, orange 2, and red 3. So wherever the patient's parameter falls, that particular score is assigned. Then you identify the clinical risk. I'll talk about this a little bit later. And then you initiate a response. Initiating the response is also fourfold, which I will discuss as we go along. Now, first step is documenting the vital parameters. So here you can see we are talking about respiration. And here the nurses have documented the respiratory rate. So you can see that as long as the respiratory rate is normal, it is in the white area. And whenever the respiratory rate goes up, it goes into the yellow. So likewise, if the respiratory rate goes more higher or becomes low, it will go into the red and alerts the nurse that there is something wrong with this patient. Oxygen, so I'm just talking about certain peculiarities of the chart. So otherwise, all the parameters are marked in the same way. The saturation has got two scales. One is called the normal scale, which is the range is between 90, more than 96 is normal. And the second scale is used for patients with hypercapnic respiratory failure or type 2 failure, where the recommended oxygen saturation is 88 to 92. So when the nurses take out the MEWS chart, they call the doctor, or in the doctor's orders itself, they tell the nurses which scale to be used. And it is the doctor's responsibility to strike out the chart scale which need not be used. So I already explained this. So the supplemental oxygen is the other additional feature. Whenever any patient is on supplemental oxygen, they are given a score of 2. And we also are able to indicate what is the device which you use for supplemental oxygen. Blood pressure is also another peculiarity because in MEWS scoring, we only use the systolic value and not the diastolic, because hypotension, when it happens, it reduces the systolic pressure, and and by just tracking the systolic pressure, we can actually track the deterioration of the patient. In hypertensive patients, the pressure has to be very high for it to be of any danger, and even otherwise, for a very hypertensive patient, the treatment is not very urgent. We just treat them with oral antihypertensives. So therefore, the urgency is more for the systolic measurement. That is the reason only the systolic BP is considered for MEWS measurement. The level of consciousness uses the ACVPU scale, that stands for alert, confusion, responding to verbal stimuli, painful stimuli, or unresponsive. And as you can see here, anything other than alert is given a score of 3. So this is how the MEWS chart is designed. Now, when you assign a score, as I told you, wherever the parameter falls, here, for example, the patient's respiratory rate is 20, you write the value in the white area and you assign a score of 0. So that is how you assign the score. Now, the other important thing when you assign the score is to recognize when there is a red score. Here you can see the patient's respiratory rate gradually has gone up, and then in the 5th reading, it's gone to 32. So once it goes to 32, it is the red score, and the color-coded chart easily alerts the nurse about the severity of this condition. And we will also talk about the significance of red score as in a couple of slides. Now, based on the individual scores, as you can see in this example, we add up each of the vital parameter scores and then we total the score. Here, for example, this patient in the first measurement, the score is 4. You can see here, that's the score of 4. So this is how you calculate the total score. Now, I told you about the clinical risk. So based on the total score, you classify them into these categories. Whenever the patient has got a score of 0, then the clinical risk is no risk. When it is between 1 to 4, it is low risk. When it is 5 to 6 or red score in any of the vital parameter, red score means it's 3. So in any vital parameter, if it is 3, then it becomes a moderate risk. And when the score is 7 or more, it becomes a high risk. Now, here you can see in this example, there is a patient who's unconscious, and therefore the score is 5. And also there is a red score here. So because of these two reasons, we have to put this patient as a moderate risk. Now, once you calculated the total score, this is the most important. It is not an observation chart. This is where the nurses initiate a response. So they initiate a response in 4 ways. They first know how urgent it is to act. Then they know which seniority of staff to call for. And they themselves can change the frequency of monitoring according to the score. And they also take a decision whether the patient has to be nursed in the ward or to a high dependency or an intensive care unit. So all these decisions are taken by the nurse. So here you can see the score is 0. That's the first row. The urgency of response, no action is required. Nobody needs to be called. The frequency of monitoring is 4 to 8 hourly, and the clinical area is the ward. Actually, when the score is 0, you can actually measure the vitals only once in each shift. Now, in our hospital, it is 8 hourly shifts. But when we had a discussion with the physicians, because it was so new to them, they were afraid that because usually we do 4th hourly TPR. They didn't want to make it 8th hourly. They were afraid that we will miss something. But actually, it is not so. The MEWS chart clearly distinguishes between a no risk and other risks. So as long as the patient stays in white, you can actually monitor the patient's vitals only once per shift, and thereby freeing up the nurse's time to do other work. So when the score is 1 to 4, again, the urgency of response is routine, but they have to inform the duty postgraduate. And they increase the frequency of monitoring to 2nd hourly. This is what we do in our hospital, but still the patient is nursed in the ward. And when the score is 5 or 6 or a red score, then the urgency response is urgent, and they have to inform the senior resident and also phone up the consultant in charge to tell that this patient is actually having a problem. And they increase the frequency of monitoring to hourly. And finally, when the score is 7 or more, it is high risk. It's an immediate response. Both the consultant in charge and the intensivist are informed, and they make arrangements to transfer the patient to the ICU, and they've also plugged the patient to a multi-parameter monitor. So the continuous monitoring is being done. So this is how the response is done. So let me now share how we went about to implementing this. It is all so new to us, and when we looked at the MEWS chart with all its colors, and the book which comes from, we use the National Early Warning Score booklet, it is pretty complicated. So we took our time to implement this. So we based it on the National Early Warning Score of the NHS, but we made some modifications and implemented in the chart in our hospital. So the quality team presented this concept because I had worked in the UK and I was familiar with this. So we presented this to the nursing management and the leadership. The nursing management was very supportive, and because they could see the advantage of this chart, and we got the support and approval. So then we worked along with the nursing leadership, and we initially adapted the news chart to our terminology. For example, the temperature was centigrade, we changed into Fahrenheit, and some terminology which is more UK based was changed into Indian terminologies. So that was done first by the nursing leadership. And then we were clear what we wanted to focus. So we said we are only going to focus on nursing actions, and the nursing actions will focus on early response based on the score. The nurses themselves can change the frequency of monitoring, and they will be empowered to call the senior or the most capable doctor and informing the ICU. So this is a tricky issue, because next we had to convince the doctors, because the doctors in our hospital are so used for the residents calling them. The nurses, for almost 25 years have never directly called the doctor. So this was a major culture shift in our organization, and we had to do a lot of firefighting here. So then we had a series of meetings with the consultants, middle grade and junior doctors to tell them about this and the advantages. They did accept the usefulness of the chart, but there were several reservations, especially among the senior consultants, and there was a lot of discussion. And I remember I used to have running arguments in the corridor, because they'll go see a patient and get so frustrated at the new chart, they'll come out and I'll be actually doing the rounds and they'll pick up a fight with me. But we stood our ground, and the main hurdle was changing from a well-established practice. So luckily the clinical quality team were all practitioners. Now we had an ENT surgeon, I was a general surgeon, and then there's an emergency physician. So we were champions in our own departments. And we decided to do a pilot in a single, the smallest ward in our hospital, and took our time. We did 3 months, and the nurses were initially trained on the use of MEWS chart, and we gave them a workbook. We also gave them a badge, along with the nursing, ID card, the color-coded small plastic card with the response, what they had to do, for the easy reference was given to them. The challenges, as I told you, were modified look and functionality of the chart, empowerment of the nurses. The nurses also took some time to know that they were responsible for this, and managing the consultant frustration that was mostly directed towards the nurses, as you are all well aware. But there are several genuine concerns as well. So we kept the communication open, we encouraged feedback, and we changed certain things as well. For example, initially we just put dots for each parameter. That's what the National Early Warning Score in the NHS does. But consultants pointed out that we need to know the value of the parameter. What is the respiratory rate? What is the BP? No, you can't put a dot like that. We knew, then we understood that it was important. And then the nurses started entering the actual parameter in the, so we had to modify the chart, reprint it again, make it a little bit bigger to accommodate the parameters. And we also modified the systolic and diastolic, the BP area, because if you see the original, there is no way to put the diastolic. Here we put the diastolic as a separate row, and they could write the value of the diastolic in the lowermost row, but the score is always 0. So this is how we modified the BP part of the MEWS chart. Then after the pilot, when people were happy with it, now we've expanded to the whole hospital except the pediatric and the labor room. And now they are in the process of developing the PEWS and MEWS chart. We're still not implemented that. So in conclusion, I would say the challenges in MEWS chart are both human and the chart itself. The main problem we faced was the doctor's buy-in, and also the nursing empowerment, for the nurses to recognize that they had this empowerment to do it. And also whenever new staff joined, there was a dip. They had because nobody is used to this chart in any hospital. So when they come and see this chart, they all get, they don't know how to use it. So we continuously need to train, and with the nursing turnover, it's a difficult task. So that is another challenge. The tool itself, again, is a challenge in that it is a complicated interface and it uses 2 charts for saturation. Only systolic values used for BP. And there is a problem with unconscious patients, which I will tell you. And whereas, because when you see the unconscious patients, sorry, I'll talk about that a little bit later. So here you can see, this is the TPR chart on the right. You can't really see any difference in the way the patient is deteriorating. But here quickly, here in the left, you can see whenever the respiratory rate goes up or the pulse rate goes up or the temperature goes up, the color changes, and therefore it alerts the nurses of the deterioration. So the usefulness in our experience is, we see that there is an early response. The nurses are able to change the frequency of monitoring and call the, senior most, or what I call the capable doctor. They inform the ICU, and whether it is reducing the code blue calls, we have to do a study yet, because now we have just expanded the whole hospital, and we will wait for some time, and then we can compare the code blue calls in the next 6 months and compare it to the same period last year and see whether the number of code blue calls are actually falling. And now we will update you on that. So in conclusion, I can say that the MEWS chart is now well established in our hospital. It has resulted in empowering the nurses to recognize the deterioration of the clinical signs early. And this should reduce the number of code blue calls and the in-hospital CPR events. And in the future, with the EMR, color coding and calculation can all be automated. And you can even integrate alerts or alarms into the system. So that's what I think the future holds for the MEWS chart. Thank you so much, and thank you, Kaho, for giving me the opportunity for presenting our experience of implementing the MEWS chart in our hospital. Thank you so much.
Thank you, sir.